for 3 months, and she also complained of blood and mucus stools for 3 months. She has passed 4 to 5 times blood and mucus stools per day, associated with the nocturnal frequency of 1 to 2 episodes per day, which was small volume, more of blood than stools. And however, there was no associated abdominal pain, or there is no any urgency or tenesmus. However, there is no history of abdominal pain, abdominal distension, altered sensorium, or any GI bleed, or systemic manifestations like arthralgia, arthritis, skin rash, recurrent oral ulcers, and redness of eyes. There is no history of any night blindness, cramps, or bony pain, or easy bruisability. There is no history of anorexia and weight loss. She is not a known case of diabetic, hypertensive, thyroid disease, or tuberculosis. There was no history of any chronic drug intake or alternate medicine use. Under personal history, she took both the vegetarian and non-vegetarian diet, and she attained menarche at the age of 12 years, and she had a regular menstrual 3 by 30 days menstrual cycles. And the family history was not significant. There is no history of any similar illness or any liver disease in the family. On developmental history, her milestones were appropriate for age, and there was no history suggestive of any growth retardation. She has completed higher secondary school education, and after that she discontinued her college due to the illness. Coming to the examination, she was afebrile at the time of presentation. There was mild pallor was there, icterus was there, there is no pedal edema or clubbing, there are no other signs of liver cell failure. There is no biter spots or dryness of eyes or bony tenderness. There is no erythema nodosum or pyoderma gangrenosum. And her vitals were stable, and there was no tachycardia. Coming to per abdomen, there was a firm non-tender hepatomegaly was there. There is no splenomegaly or free fluid clinically. The examination of other systems and PR examination was normal. Coming to the investigations, her hemoglobin was 9.1. There was no leukocytosis, and the platelet count was normal, but the ESR was elevated at 60 mm per hour, and the CRP was positive. Under random blood sugar and renal function test and electrolytes were normal. Her TSH was 0.8. Coming to LFT, the total bilirubin was 17 with the direct hyperbilirubinemia. Under OTPT were 3 to 4 times elevated with SAP of 638 and GGT of 226. And the albumin was low, and the INR was 1.5, and the screening for viral markers were negative. So there is the LFT shows direct hyperbilirubinemia with both cholestatic and hepatocellular pattern. In view of her age and her sex, we suspected autoimmune hepatitis presenting as cholestatic jaundice. So we proceeded with the autoimmune profile. Her ANA was positive in 1:80 titers, and other autoimmune markers were negative, including P and K. Her IgG levels were elevated, which suggest underlying autoimmunity, and her serum bile acids were also elevated, which tells cholestasis. And the workup for Wilson disease was negative. The ultrasound abdomen showed normal liver echoes with mild IHBRD, and the CBD diameter was 6 mm with concentric wall thickening. So in view of the dilated system, we have proceeded with the MRCP. The MRCP showed luminal irregularity with beaded appearance of the biliary radicals, sectoral ducts, the hepatic ducts, and the common bile duct. And the features were suggestive of sclerosing cholangitis. And our colonoscopy showed multiple small ulcers with erythematous spots with loss of vascular pattern involving the ascending colon, transverse colon, and sigmoid colon with sparing of the rectum, and biopsy was taken. And biopsy showed the loss of orientation of crypts with crypt shortening as well as the distortion of the crypts. And the lamina propria was infiltrated with the lymphocytes, plasma cells, few neutrophils, and there was focal areas of crypt abscess. The findings were suggestive of colitis with activity. Under upper GI endoscopy showed portal hypertensive gastropathy. Her fibroscan value was 3.37. Her CA19 and CA levels were normal. So we suspected underlying autoimmunity with cholestatic pattern of LFT. So with MRCP and MRCP showing features of sclerosing cholangitis. So to confirm the autoimmunity, we proceeded with liver biopsy. Then liver biopsy showed there was a portal and lobular inflammation with lymphoplasmacytic aggregates as well as the pseudo-rosetting of hepatocytes suggestive of autoimmune hepatitis. And there was mild bile duct damage with ductal proliferation suggestive of obliterative cholangiopathy, as well as the periportal stainable copper deposits which suggest chronic cholestasis with portal and periportal bridging fibrosis. So with this, we have made the final diagnosis of PSC autoimmune overlap with ulcerative colitis. Coming to discussion, this PSC autoimmune overlap is a rare entity, and this overlap responsible for 5 to 10% cases of cases in PSC, and this overlap is more common in children and young adults. The associated IBD can present before the onset of PSC or after several years of onset of PSC. The IBD phenotype in PSC is usually unique, and it has certain characteristic features. Most of the time it involves the entire colon, and it remains silent, and there will be rectal sparing with a more severe right-sided colon involvement. There will be predominant backwash ileitis with increased lifetime risk of colorectal cancer. And there are also case reports that suggest in patients with concomitant PSC autoimmune overlap, there is increased severity and severity of UC, which is refractory to treatment. And PSC per se is an independent risk factor for colorectal cancer and ulcerative colitis. And compared to isolated ulcerative colitis, patients with PSC and UC have increased risk of dysplasia and colorectal cancer. And they used to have an early onset of colorectal cancer with more predominant of involvement of right colon. So patients with this overlap and involvement of ulcerative colitis should warrant annual surveillance colonoscopy and biopsy. So there is no validated diagnostic criteria for the PSC autoimmune overlap, but how the International Autoimmune Hepatitis Group suggests to treat the dominant disease. And prognosis wise, the PSC autoimmune overlap has a better prognosis compared to the isolated PSC, but has a little graver prognosis than isolated autoimmune hepatitis. These patients with PSC autoimmune overlap associated with IBD, they usually have a low mortality, and they respond better to the immunosuppressants like steroids, azathioprine, along with mesalamine and ursodeoxycholic acid. So the ESL recommends prophylactic UDCA treatment in patients with high risk, like family history of colorectal cancer or past history, or the patients with active colitis. So the patients with overlap, those who are unresponsive to treatment, ultimately should be planned for liver transplantation. So before the PSC has the propensity to recur in the post-transplant liver. So to reduce the risk of recurrence, it is advised to treat the IBD before planning for liver transplant, as well as to consider colectomy in patients with advanced colitis or dysplasia. This is the study by Bellotin VR et al. They reviewed 103 PSC autoimmune overlap cases, which was reported from 1994 to 2020. In 109 patients, the 57% patients had IBD with a predominant ulcerative colitis. And also there is a case report with this overlap of 3 entities along with the membranous glomerulonephritis. They attributed this membranous glomerulonephritis as an extra-intestinal manifestation of IBD. Thank you.
How was the patient managed?
Actually, she was started on steroids, ma'am, and in tapering dose, and then added azathioprine along with mesalamine in UDCA, and ultimately she was registered for liver transplant workup, ma'am.
What happened to the jaundice?
Ma'am?
What happened to the jaundice, the cholestatic jaundice?
Actually, it remained same, ma'am. The elevated bilirubin. 3 weeks back, she was admitted with again worsening of LFT, the pneumonia and paranemonic effusion, ma'am. She succumbed to death.
Your patient had IBD first, or did he have?
No, sir. First PSCS presentation.
By history?
No, sir. She had 8 months history of jaundice, 3 months history of blood and mucous stools.
Any other questions from the audience?
In this PSC, what do you think it is? It is predominant large duct or small duct, or what? I mean, the jaundice does not explain based on the MRCP was done, I think, no?
Yes, ma'am.
So yeah, so it showed PS diffuse, is it?
Yes, ma'am. Both extrahepatic.
So how often do you have the severe cholestatic jaundice in this type, no? I think I'm just wondering whether there's a PFIC component or something else that was there. What was the alpha and gamma GT? Elevated.
GGT was 300.
IgG4?
IgG4 not done. No.
Was pneumonia because of any leukopenia due to azathioprine or something?
No, sir.